Hi, I'm Dr. Khan, Saud Khan from Neurology from Titus Regional Medical Center. Today, we're going to cover a Neurology Nursing Assessment for our patient care. In this lecture, we're going to cover different scales which are very beneficial for our patients. In this lecture, the main scale we're going to cover wire scale, GCS, and modified Renkel scale. So neurology history is very important because 90% of the diagnosis comes from the history. As a neurologist, we are taught that you have to spend at least 90 minutes to get a good history. But in this situation, it is not possible. Most of the time, when we try to see our inpatients, we try to get good history from our nurses. This is usual protocol from most of the neurologists in the standard practice, that when they try to see inpatient, they go and talk to the nurses. The nurses can provide us very different information. It can be like, when was the last time patient was driving? When was the last time patient was working? What was his job? When did he retire? And what did he do after the retirement? Does the patient live alone or with significant others? Or is there any change of personality has occurred, or caregiver has seen some change of memory or personality? Also, sometimes it can give us some information. What is the usual schedule of a patient? Does a patient has a reading habit, some exercise pattern is there or not? Or does the patient remember what medication and what dose do they take it? Also, in the same context, do they take care of their own finances, or someone else help them to take care of their finances? All these are very baseline history which help us to find out what was the patient doing before he or she came to the hospital, when did the symptoms start, and how it evolved. Sometime we see demented patients are there, although they might be having history of memory problem for years, which caregiver hasn't noticed it, but they might be having these problems with their driving, or might be they are not having some social interaction. So all these things becomes relative in the diagnosis. The best way I can tell you that as soon as you enter the patient room, observation is a key there. Eye-to-eye contact, we are talking about normal psychology, whether the patient can see you, can track you, do they have a smiling face? That's also give us their emotional status, and that's also very much relative in neurological diagnosis. And communication skills also helps. Let the patient talk, and do not stop them in conversation. Usually, first 3 minutes are good enough for any patient to give a good history. It is a well-said phenomena we know in neurology that first 3 minutes belongs to the patient. And in first 3 minutes, if whatever the history they give us, we will get the diagnosis. After that, most of the time, this is usually out of context. So I will strongly recommend that whenever the patients are spending their time with the patient, getting the EPIC information into the computer, all the relevant information, whether it is past medical history, past surgical history, social history, family history, allergies, or review of the system, let them talk. And first 3 minutes, it's a key for the diagnosis. So the best way we were taught, what brought you to the hospital? And whatever the patient says, for example, I came for headache, or I was having a worst headache of my life, or I was having some memory issues for the last 2 days, please write this specific statement and don't paraphrase too much there, because that's a very relevant information and give the diagnosis. Along with that context, also, whenever you are seeing the patient and examining the patient, see how the eyes are, especially the pupil equal and reactive, equals are there or not, even during the conversation. Also look at the eye tracking. Sometimes whenever we are evaluating the patient initially, then they can have an event or spell. For example, patient can have a seizure or patient can have a stroke, unfortunately. In those situations, the eyes are our friend of a neurologist. If a patient is having seizure, for example, while you are evaluating the patient, eyes, that information that is eyes is closed or open is very important. If you see the data research, whenever any spell occurs and eyes are closed, then most likely these are non-epileptic spells. When the eyes are open, then if the eyes are going right or left, are they under patient control or not under control? And also some nystagmus at the end can help. So anytime that information, which nurses can see it, we are talking about 60-second information, which we cannot see because by the time we are involved, the spell is over and we very much dependent on our nurses. So if we can focus on the eyes, we can focus on the facial cheek and the hand movement, especially with the thumb movement can help us. If a person is having, during the conversation, start having staring spells, eyes open, and then lips smacking, and start having this movement of the thumb, we are talking, and then 10 seconds, and then patient is back to a normal. This is a small seizure, which you can only get it. By the time we are consulted, we don't have that information. So that will make you a smart nurse. So if you can take that information and pass it on to the neurologist or physician, that can be very beneficial. In the same context, if a patient is having a stroke-like symptoms, just remember, stroke usually occurs suddenly. There are usually in hospital setting, we are talking about two major diagnoses. Either patient will have a seizure or patient will have a stroke. In stroke, the patient may have sudden onset of speech problem. It could be expressive aphasia, it could be receptive aphasia, or it will be some fluency problem. Patient will have impaired speech. They can have facial droop. They can have one arm and leg weakness. That will be unilateral. Most of the time, those symptoms which occur within a second, 60 seconds to maybe a minute, 2 minutes, maybe up to 10 minutes, that most likely these are vascular event. So these are the information which usually nurses witness it, and by the time we are involved, those are very much we are dependent on your information. So that could be a very good information if you can pass it on to the neurologist. In the same context, sometimes patients can have intermittent drowsiness, and sometimes the third most common cause, which in neurology patient or in the hospital patient we see, is encephalopathy. Encephalopathy can be intermittent. That in the morning when you evaluated the patient was awake and talking everything, and by the evening, patient was having baseline dementia. They started having some agitation, aggressive. So that is hyperactive encephalopathy. But on the other hand, some patients can have very slow mentation. They are unable to talk. They don't have any attention span. They cannot answer your any question, and they can have very much hypoactive encephalopathy. So again, that can be great information from our nurses that when they witness the spell, was it hypoactive or hyperactive? And then how how long did it take to complete it. So these are the major information by the history and by the time when you are putting all the records in the EPIC, that can provide us good baseline history and possible diagnosis. In the same context, we're going to try to cover some scales, especially in our Titus Regional Medical Center. I will strongly recommend that we should follow strongly in our patients. On the floor patients, we should do wire scale every shift, along with maybe modified Rankin scale at the time of admission and at the time of discharge. While in the ICU setting, I will also recommend do wire scale every shift, plus GCS scale, which is very easy if the patient is not intubated. And in the ICU context, please, nurses need to follow the protocol of the patient should be off the sedation, or the sedation vacation should be there so that they can examine the patient. Because sometimes patient can be altered and we really do not know when is the time of onset or when was a patient was last seen normal. So there is one context in the strokes evaluation we should understand, last seen normal concept. So patient is seen last seen normal means when was the last time grandma was seen normal. For example, grandma goes to night at sleep at 10 p.m. She was walking, talking at her baseline, and at 4 o'clock she wakes up, again walking, talking, goes to the restroom, goes back, and when 6 o'clock she is not able to talk. So given this scenario, the last seen normal may be at 4 o'clock because she was able to walk and talk normally at 4 a.m. But if nobody has seen at 4 a.m., then the last seen normal will be 10 p.m. And this time is very important because any time when the patient comes for altered mental status, patient is unable to talk or one side weakness, unilateral weakness, then this could be a stroke until proved otherwise. If the patient is last seen normal is 4 a.m. and patient is within time window of 4.5 hours, then they can meet the criteria for IV TPA. But if the patient was last seen normal at 10 p.m., then unfortunately we cannot give TPA. We may have to do some testing to meet the criteria. Nowadays, after the wake-up study, which was recently published, that any patient who wakes up with the symptoms and patient is still having one-sided weakness, meet the criteria for stroke, and then we need to do STED MRI to make sure there is no flare sequence changes and DWI changes are there, and there should be a mismatch, then we can still give TPA in those cases. So this type of information, last seen normal, for example, will also be applicable in the inpatient nursing situation. So if night nurse rounded at 10 p.m. and the patient was doing okay, at 4 o'clock, 5 o'clock, the nurses gave the medication, patient was able to talk, took the medications, no focal deficits were seen. And if the patient has a new symptom, one-sided weakness at 8 a.m., we can still give TPA if we have that clear-cut information. So nowadays, there are different scales we are using, and scales are used in hospital setups so that we can communicate with each other. Scales are done mainly created by some researchers, scientists. They did some studies, and based on their studies, the data came and it was validated. This is the scale which was presented in 2016 American Academy of Neurology meeting, wire scale, by Dr. Derek Holder. He was from University of California, Davis. This study was mainly implemented by the neurologist. And the idea was that if neurologists are able to do proper exam of a patient, we should be able to rule out or rule in large vessel occlusion. Wire scale stands for W stands for weakness, I stands for inattention, and R stands for repetition of a phrase, and E stands for eyeball deviation or vision loss. So weakness could be one-sided. Right-sided weakness, it will be localized to the right-sided weakness will be localized to the left hemisphere. If it is left-sided, then it will be vice versa. If patient has inattention also known as neglect. Neglect most of the time is on the left side and usually covered by the right parietal lobe. And repetition of the phrase, if the patient is able to repeat a sentence, today it will be a very nice day, then usually the speech understanding and repetition comes from the left hemisphere speech area, which usually include Wernicke area, Broca's area, which is well connected with the conduction fibers. So if I ask the patient to repeat a sentence to anything, they are able to hear it, which goes to the Wernicke area, they comprehend it, and with the help of arcus funicalis, it goes to the Broca's area, and patient is able to speak that phrase. Eyeballs is done for the eyeball deviation. In that study, when first it was created, wire scale, it was that eyeball could be deviated on one side or the other. And then they come up with the score that if wire score is more than 2, then that will suggest large vessel occlusion. So what is the significance of weakness? Weakness is usually involved start from the cortex, motor cortex. It forms the fibers, corona radiata fibers, goes to the internal capsule, and then ultimately in the brainstem and in the medulla it decussate and goes to the other side and control the muscles of the upper extremity and lower extremity. So if the person is weak on the arms or legs, then we are checking the circuit involving the corticospinal tract from motor cortex to the whole involvement of the extremity. The inattention, on the other hand, most of the time is usually evaluating the right parietal cortex. And repetition, we already talked about the left hemisphere speech area. Eyeballs deviation usually occur because of the frontal eye fields, which are on the frontal region, frontal lobes. And when one lobe is disconnected, the other frontal eye field push the eyeballs to the other direction. So that's how we should be able to diagnose or localize the lesion. So when they did the study, then when they put the data, they compared different scales. The scales include LAMP scale, CPSS scale, RACE, Van scale, FAST ED scale. And they compared with that with the wire scale. So if you look at the different scales, sensitivity and specificity, usually these are among 80s. And Van scale has 100% sensitivity, but specificity was 80%. This is another graphic way he presented sensitivity and specificity of different scales. In his data, wire scale was 95% sensitive, and wire scale was 94% specific. But remember, this data was done by the neurologist, and a neurologist examination depending on the acute event. What we are trying to do at Titus is we want our nurses, our EMS, start doing this wire scale so that we should be able to diagnose large vessel occlusion as soon as the EMS bring the patients. so that we should be able to treat them either with IV TPA or thrombectomy. So this is the cartoon which I tried to make it. In this cartoon, we can see the weakness of the arm. All it needs to be shown, we can ask the patient to raise the right arm, and only for 5 seconds. Eyeballs, we just have to examine, eyeballs are not deviated, and then repetition of the phrase. And along with that, we modified with the vision. So we will ask the patient to count the fingers on each side, 2 and 4. And what it does, it also, with the modified wire scale, which we are trying to implement, not only it is involving the frontal field by the eyeball, it is involving the motor cortex, it is involving the parietal lobe. We added on occipital lobes so that even the vision will not be missed. Remember, vision can cause big time disability. So we don't want to miss the vision issue here. So it's the beauty of this scale is it takes only 60 seconds, while all other scales, which are very good, NI-stroke scale is a very good scale, but then it takes at least 8 to 10 minutes. And then there is a question of about intraoperative reliability. In this case, since it is very small, less variable, and because it is less variable, the inter-ratal reliability is very minimal. So, and whatever the data we are collecting, most of the time, it is true positive, and if it is falsely negative, there will be chronic MCO occlusion. So this wire scale needs to be done by our nurses on every shift, and they should communicate with each other or even with the physician that wire scale on the shift last night was 0, right today it is 2 or 1. That means there is a significant changes there, and that will help us to make sure there is no acute stroke is coming. So that will be very beneficial for us in communicating with each other and to prove that simple scale which can be done in 60 seconds, and we can diagnose large vessel occlusion. Another scale we would like to cover is Glasgow Coma scale. So Glasgow Coma scale was invented in 1974 at University of Glasgow by Dr. Teasdale and Brian Jennett. The whole idea, they worked on first loss of consciousness and trauma patients. And they wanted to collect the data and put the data in, and they come up with this different examination finding on patients which can give us some information. The Glasgow Coma scale is divided into EVM, electric vehicle machine, which we all know nowadays, meaning E stands for eyes, V for verbal response, and M for motor response. So what is this GCS, Glasgow Coma scale? Glasgow Coma scale can help us evaluate cortex, subcortex, and brainstem. That's a very good examination, which again can be done within few minutes. So to evaluate that, we will try to cover eye evaluation, verbal evaluation, and motor evaluation. The eye, verbal, and motor response usually are 4, 5, 6 maximum. The eye response maximum is 4. So if my eyes are open and I'm talking to you, then my eyes 4 is open eye. But if my eyes are closed and one of the physician asks me to open my eyes, so I'm opening my eyes with the auditory response, then it will be E3. But if my eyes are closed and somebody had to pinch me to open my eyes, then it will be E2. And if even after pinching, I'm not opening my eyes, then it is E1. Verbal response, if I'm talking to you, making sense, hopefully, then this is V5. But if I'm confused or patient is confused, then doesn't know or is disoriented, doesn't know who is the president, doesn't know what day it's today, then it will be V4. And V3 could be some out of the context words. V2 can be incomprehensible words, but it will not have any meaning. And V1 will be no verbal response. Motor response is greater than 6. M6 is normal. You ask the patients, make victory signs, make 2 fingers, wiggle your toes. That's M6. But somehow patient is not responsive in ICU, comatose patients, and we pinch it, and patient is able to localize it, it will be a M5. And if patient is not able to localize but withdrawing it, then it will be M4. And if patient is having flexion posture, then it could be decorticate, abnormal flexion. And M2 will be abnormal extension, decerebrate. While M1 will be no response. So let's find out how is it helpful. So if the eyes are open and patient is able to talk, track, visual tracking, as soon as I enter the patient's room in the ICU, patient is tracking, the cortex of the eyes, the frontal eye fields are providing the movement of the eyeballs. So at least cortex is working, okay? If we pinch, if we patient auditory inflammation, we ask the patient to open the eyes, patient hear it, opens the eyes on the command, the hearing goes to the Wernicke area, patient process it, comprehend it, and then frontal eye fields open, then again that track is open. But when we pinch it, pinching is so the E1, the E4 and E3 is very much cortex is involved. While E2, where only the pinching, patient can open the eyes, spinothalamic tract is open, goes up the brainstem, thalamus, and then come back, then it's more likely subcortical area or upper midbrain. And whenever it is not opening the eyes, then it could be brainstem, but again, it's not reflexing. The reflex is not present. In the verbal response, if the patient is able to talk, make sense, then cortex is working. If they are a little bit disoriented, they do not know what date is today, they do not know who is the president, then again, that is cortex, but cortex among cortex are not connecting with each other. But still, their words are there. It is a little bit, they are disoriented with the time mainly. But the V3 usually out of the context words, even in that case, cortex is working and that's why their vocabulary is there. They're making some words which is out of the context. But still the cortex, the words comes from the cortex, just remember. But as soon as patient is having incomprehensible noise, sounds, moaning when you are asking or when whatever their verbal response is, that is usually brainstem is functioning. So that's how it helps. Cortex, subcortex, and brainstem. Now coming with the motor. When the motor is able to move two fingers, victory signs, wiggling toes, then means the whole corticospinal tract from brainstem and spinal cord is intact. Within few seconds, that's the circuit we are finding out. If patient is able to localize, still localization, what happens, you are giving the painful stimuli and it is processing and cortex is still involved, and that's what cortex is telling our electric circuit, go and take away that hand. So that means still that cortex is involved. But as soon as we are withdrawing only, then we are talking about very much brainstem reflex. So, and whenever patient has decorticate posture like this, usually that means the red nucleus is hyperfunctioning. So lesion is above the red nucleus, and red nucleus is in the midbrain. But whenever the patient has a decerebrate posture, that means the lesion is below the red nucleus. It could be below the midbrain, it could be in pons, it could be in medulla, and that could be very detrimental. And no response could be due to different reasons. Sometimes sedation, sometimes, paralysis, neuromuscular blockade. So in summary, when we try to examine the patient in the ICU, so we usually use in ICU patient GCS a lot, and because that help us what was the baseline for our patient yesterday as compared to today. And again, this can help the nurses, ICU nurses, when they are trying to communicate with each other. Overall, the normal GCS is 15 is normal. GCS 8 can show that altered mental status is there, and that sometimes can be very dangerous. At that time, sometimes we have to make a good judgment whether to just take care of the airway at that time when the GCS is 8. So usually the lowest GCS is 3, the highest GCS is 15, and GCS 8 is a most common reason we try to intubate the patient to protect the airway. We need to communicate with each other with the GCS. And usually, if we don't, sometime in the ICU patients, when the patients are intubated, then unfortunately we cannot do the verbal evaluation. So we should say not tested. So that's the one thing we need to do that. So whenever a patient is sedated or patient is paralyzed, then we should say not tested motor part. And all other part we can document it clearly. For our ICU nurses, I will strongly recommend that they should be big proponent for the sedation vacation so that they can examine the patient, because that sometimes help us to find out when exactly the event occurred. So these were the references there. Let's coming to the modified Rankin scale. And again, I would strongly recommend that our nurses on the floor, they need to do modified Rankin scale on every admission, on the admission day, plus on the discharge day. And that help us as a neurologist and a stroke specialist a lot. And the reason for modified Rankin scale, why we are favoring modified Rankin scale in this situation, because sometime we can do some intervention based on this modified Rankin scale. So nowadays, if the patient is able to walk and their modified Rankin scale is 2 to 3, then they can be a candidate for intervention. So what is a modified Rankin scale? Modified Rankin scale is graded from 0 to 6. And just to give you a history about modified Rankin scale, it was created by Dr. John Rankin in 1957 at Glasgow Hospital in Scotland. And it was modified into Rankin scale in 1980. And then again it was modified from 0 to 6 in 2008. There is some speculation is there. When first it was invented, it has only 5 numbers, but now it is 6. 0 stands for no symptoms of the patient, while 6 stands for patient is dead. 1 is a patient has some symptoms but no significant disability. Third, second patient has slight disability but some symptoms and some signs. Third, patient has moderate disability, but they are able to walk. And fourth, patient has moderate to severe disability and they are unable to walk. And fifth, patient has severe disability and very much dependent on nursing care because of incontinence and all other cares. The best way the way I can remember, maybe it can help you guys. 6 is dead, 1 is 0 is no symptoms. 1, will be some symptoms, but they are still going back to the normal. The main thing, I think, 4 is the key. If you look at the digit 4 needs a cane to walk. So 4, whenever the patient starts using a walker or assisted device, that's where make a big difference. Just to let you know, previously, when the research was done, we wanted to achieve modified Rankin scale 1 or 2, but then we find out that even modified Rankin scale 2 and 3, still the quality of life is not so bad. So whenever the patient has any large vessel occlusion and they meet the criteria for large vessel occlusion and their baseline modified Rankin scale is 4, they will not be a good candidate. But if their modified Rankin scale is 3, meaning they are able to walk without assistance and talking, able to walk, talk, then still they can be a good candidate. So usually this has been used in many years, for 30 years in the research. It has 6 divisions, and the inter-rater reliability is not so great for this scale, but for a person who's doing it, if it followed the whole protocol, then it can be. What are the questions usually you have to follow? You have to ask the patients. It's very much subjective depending on the patient. Do you have any symptoms that are bothering you? Are you able to do the same work as before? Are you able to keep up with your hobbies? Have you maintained your ties to friend and family? Do you need help making a simple meal, doing household chores, or balancing a checkbook? Do you need any help with shopping or traveling close to your home? Do you need another person to help you walk? Do you need help with eating, going to toilet, or bathing? Do you stay in bed most of the day and need some constant nursing care? So these are the protocol we have to follow so that we can be consistent and reliable. Before we end this talk, I would like our nurses to follow this protocol, this acronym, DOCTOR. We are Primary Stroke Center. We would like our patients to follow standard of care. We want to follow the core measures. This is the mnemonics that can help us to remind that we are not missing anything which is relevant to our patient. DAAT.Doctor, DR, D stands for dysphagia screen. So patient should get dysphagia screen from the ER. A stands for antiplatelets. So aspirin or Plavix will be good enough. A for antilipids, maybe atorvastatin 80 milligram high intensity, according to new guidelines. A for anticoagulation. Some patient may need Coumadin, or they can need Eliquis for atrial fibrillation. T stands for IV TPA. We need to either consider or say patient did not meet the criteria for TPA. D stands for DVT prophylaxis. So during the TPA, we try to go for SCDs, and then after 24 hours, we put the patient on heparin as compared to Lovenox. The reason we prefer, or I prefer heparin as compared to Lovenox, because we have more experience with heparin, and heparin effect is usually gone in 2 to 4 hours. For example, let's say patient is given heparin at 8 o'clock in the morning, 5,000 units, and at 3 o'clock there is alternate status with one-sided weakness. I will not have any problem in giving TPO in that patient, and even I will not worry about checking the labs. But if the patient is given Lovenox, then still according to guideline it is okay, but it's it's all about choices. R stands for rehab evaluation. So whenever the patients get admitted, patients should have inpatient rehab evaluation. Now to summarize, what did we learn today? Whenever you evaluate the patient, see, hear it, and observe. Sometimes just looking at the patient behaviors, that can give you a lot of information in first 3 minutes. Trust me, in first 3 minutes, most of the diagnosis can come into. History can give the diagnosis. And you nurses, and you know me, that from whenever I see the patient, I try to locate who is a nurse, and I try to get the baseline history. So you guys do excellent job, and keep it up. Baseline history is the key, and nurses do excellent job. Convey the baseline history to the treating physician. Wire score can be done in 60 seconds. It's not a rocket science. All is weakness, inattention, repetition of the phrase, and eyeball deviation and vision. Okay? There is only weakness, no numbness, nothing here. We don't care about numbness here. Numbness we don't care in this context is because even if a patient has a numbness, it could be a very small stroke, and the chances that patient will come back or recover fully is very high. So that's why the wire score is very much focused on that. Wire score can diagnose large vessel occlusion. In every shift, please do the wire score and document it in your charts. Wire score 0 meaning there is no deficit. Wire score 1 means there is some weakness, aphasia, and vision loss could be there. And wire score 2 or 3 could be meaning large vessel occlusion, when the patient can have one-sided weakness, other-sided eyeball deviation, and patient cannot talk, or patient has a neglect. All right, thank you very much, and I'm okay. I'm open to any question if somebody has it. I hope you guys have learned it.
Do you want to ask your questions?
Where are the questions? Oh, okay. So first question is, what is the wire examination used for? Is it done?
Not yet. Just give just a second. Okay, so have you answered?
Has everybody answered?
It's probably good, yeah.
Okay. So the answer is to assess a patient for large vessel occlusion. Good. Second question. Second question, how often should a patient be assessed during the wire scale?
It's probably got nothing, just a minute, we got one of them there, okay. There's 6. Ooh, you got some argument on this one. Are you ready?
Okay, so answer is A and B. Once a shift and whenever the patient has a neurological change. So whenever I think people were a little bit confused. So shift, yes, this is the answer. But whenever the patient has altered mental status, we have to document the wire scale, and that can help us 1 or 2, whether it is a new weakness, new vision loss, or a speech problem, or some other stuff. All right, next question. What should you do if a patient has a wire score of 2 or greater? Question. So Martina made these questions.
Martina makes hard questions.
Learn from the last question.
I know, that's what I thought.
Anyhow, so the correct answer is C, both A and C, called rapid response and code stroke, and consult neurology. Next question. How long should a patient hold up extremities when assessing for weakness during wire scale? 10 seconds, 5 seconds, 1 minute, or 2 minutes? Is it done?
I think so.
Okay. Yeah, 5 seconds. Question number 5. How should you assess for R when performing wire assessment? Answer by asking the patient to repeat a phrase. B. Question number 6. How should you assess for E when performing wire assessment? Answer is B, by assessing patient for eyeball deviation to the left or right. Question number 7. What score is given to a patient when assessing for wire for each deficit or positive finding? Answer, each deficit get a score of 1. Question number 8. How should you assess for eye when performing virus assessment? By assessing patient for inattention or neglect. All right. If anybody has any questions regarding the lecture or any other concerns, please let me know. Okay, thank you very much.